Welcome to the Deep Dive, where we explore the crucial, often overlooked dimensions of medical practice. When we think about orthopedics, well, our minds typically go straight to the mechanics, don't they?
Mm,
The precision of a surgical repair, the intricate anatomy of bones and joints, the physical demands of recovery. But beneath that technical excellence, there's a deeply human narrative unfolding. In every patient's journey, and indeed within every clinician's experience.
absolutely.
Today, we're really digging into how the stories we tell and those we hear can be an incredibly potent force for healing, connection, and professional growth. And that's not just for our patients, but for us as clinicians and for the future of medical education.
That's vital.
Our mission for you, our listener, is to understand how integrating these narrative approaches can fundamentally enhance clinical care, bolster clinician well-being, and maybe redefine how we approach medical education. We're sort of moving beyond the purely clinical to embrace the full human experience of illness, injury, and care. I'm thrilled to welcome a true authority on this subject, Professor Mo Imam, an adjunct professor in narrative-based medicine at Trinity College Dublin, who brings a wealth of insight as both a medical writer and a consultant occupational physician.
Thank you. It's a genuine pleasure to be here. You've hit on something vital right from the start, actually. In orthopedics, we excel at understanding the biomechanics, of a fracture or the pathology of a degenerative joint.
Right, the mechanics.
Precisely. But what's truly transformative and often, underappreciated is the profound weight of the human story behind every single orthopedic condition. We're not just dealing with data points or anatomical structures. We're dealing with lives. Lives profoundly altered by injury or illness, and the immense impact those experiences have on an individual's sense of self and their future.
Mm-hmm.
The relevance of narrative here is perhaps even more acute, I think, given the often dramatic, life-altering nature of musculoskeletal issues and the intricate journey patients undertake through recovery and adaptation.
So let's unpack this a little then. We often hear terms like narrative medicine and narrative-based medicine used sometimes, well, interchangeably or perhaps without a clear distinction.
Yes, say that, please.
Could you help us define these concepts, maybe clarify the nuances for our listeners, particularly how they might resonate in our own orthopedic practices? What exactly are we talking about when we engage with these terms?
Absolutely. Let's start with the very essence of narrative itself. It's really much more than just a sequence of events, isn't it?
Right.
Narrative is the intrinsic thread that connects experiences in our lives, placing them into a meaningful context. It's how we as humans process, understand, and, make sense of profound experiences like illness or injury. It's how we give meaning to the often quite chaotic reality of life.
Okay.
Think about an orthopedic patient presenting with chronic lower back pain. Their narrative isn't simply a list of symptoms, an MRI report, or a pain score. It's the intricate story of how that pain started. Was it a specific lifting injury, perhaps, or a gradual onset over years?
Mm.
And crucially, it encompasses how that pain now impacts every facet of their life. Their ability to work, their relationships with family, their hobbies. Maybe they can no longer play with their children or garden or enjoy their favorite sport.
Yeah, the whole picture.
Exactly. It includes their emotional state, the frustration, the fear of disability, or even the despair sometimes. It's the rich, textured story of their life with pain, not merely the pain as an isolated physiological event.
That makes sense.
Now, to distinguish the terms you mentioned, narrative medicine, or NM, it originated around the year 2000 in the United States, pioneered by figures like Rita Charon.
Ah, yes, Rita Charon.
Indeed. It's broadly defined as clinical practice, informed by the theory and practice of reading, writing, telling, and receiving stories. Now, this is a comprehensive pedagogical framework, meaning it's really about education and understanding.
Okay, the framework.
Its scope is quite broad, encompassing everything from engaging with poetry and prose to reflective writing and even interaction with visual and performing arts. Any medium that tells a story can be utilized, really.
Right.
The core purpose of narrative medicine is to provide healthcare professionals with the tools to acknowledge and process the complex feelings of experiences that naturally arise when caring for the ill. It aims to validate the patient's lived experience while simultaneously encouraging creativity and self-reflection of the practitioner. It's about honing our ability to perceive, to behold, to enter, and to represent these complex human worlds.
So if I'm picturing this correctly, narrative medicine is sort of the philosophical blueprint, the overarching framework for seeing stories as central.
Precisely. It's the why and the what, the foundational theory. In contrast, narrative-based medicine, or NBM, developed here in the UK, notably by Greenhoff and Hurwitz back in 1998, along with others like John Launer.
Right, the UK approach.
Yes, NBM places a greater emphasis on the doing the practical application, rather than solely the theoretical underpinnings. We might effectively summarize it by saying reflective practice is narrative practice.
Ah,
It incorporates elements such as literature and medicine, bibliotherapy, and therapeutic writing. So, while NM gives us the theory, NBM focuses on the tangible, everyday application in our clinics and wards.
that's a very clear distinction. So NBM is more of the practical construction kit, if you like. But for an orthopedic surgeon, constantly focused on precise, measurable interventions, how does this reflective practice manifest practically? Especially when the goal is often to fix something, not just understand it.
That's a crucial question, actually, because it gets to the heart of integration. This isn't about choosing one over the other, narrative versus, say, surgical skill.
No, of course not.
These two approaches are actually underpinned by three indispensable pillars of narrative engagement that allow us to move from understanding to action.
Okay, 3 pillars.
The first is narrative knowledge. This refers to our capacity to understand the meaning and significance of stories through cognitive, symbolic, and emotional means. It fosters a highly localized and particular understanding of a specific situation for both the participant, the patient, and the observer, us.
Right.
This differs significantly from the logico-scientific knowledge we rely on in clinical practice, which strives for universally applicable truths. Narrative knowledge helps us grasp the unique context of this patient's journey. For instance, understanding that an ankle fracture isn't just a bony injury for this person, but a devastating blow to their career as a professional athlete and their identity.
The specific human impact.
Exactly. The second is narrative competence. This is the practical skill set, the ability to acknowledge, absorb, interpret, and then act effectively upon the stories of others. This competence equips orthopedic professionals to be more attentive, better attuned to their patient's experiences, perhaps noticing the subtle anxieties a patient has about returning to work after a spinal fusion, anxieties they might not voice directly.
Okay.
It makes us more reflective in our own practice, asking, how did I interpret that consultation? What did I miss? And ultimately, it leads to improving diagnostic accuracy and guiding therapeutic direction more effectively because we understand the full human landscape of the illness.
Right. Seeing beyond the scan or the X-ray.
Precisely. And finally, we have narrative humility. This is a crucial concept, articulated by Sayantani Dasgupta back in 2008, which profoundly emphasizes the patient's ultimate ownership of their own story.
Ownership, yes.
It serves as a vital reminder that doctors and other healthcare professionals cannot simply appropriate a person's story and impose their own interpretation or predetermined solution. It acts as a necessary counterpoint to any inclination towards, well, clinical mastery, acknowledging that a clinician can never fully master another individual's lived experience. It's about respecting the patient as the primary author of their own life's text.
That's a really important check, isn't it, against that tendency to think we know best?
It absolutely is. So zooming out for a moment, these three concepts, knowledge, competence, and humility, form a robust and essential bridge. They allow us to travel back and forth between the purely clinical and the deeply human, enabling us to build a comprehensive history with the patient, rather than merely taking one from them. And that shift is fundamental to providing truly patient-centered orthopedic care.
That really brings clarity to the different facets of narrative. And speaking of stories, well, we've seen a remarkable surge in medical memoirs, books penned by doctors, nurses, other healthcare professionals. It feels like a real cultural shift.
Definitely.
Why do you believe these ordinary hero narratives, as some call them, are resonating so strongly? Not just with the wider public, but crucially with the fellow clinicians too.
You're right. There's been a significant shift in public taste, away from the traditional celebrity memoir, which once dominated bestseller lists.
Yeah, they used to be everywhere.
They did. Sales of memoirs here in the UK, for instance, surged by 42% in a single year, largely propelled by everyday folk in everyday jobs. This is in part a reaction against what some call the Katie Price effect, a term describing the phenomenon of relentless biographies of people who had nothing of substance to write about.
Right, memoir fatigue for certain types.
Exactly. That contributed to a decline in interest in certain types of celebrity narratives. Helen Garnons-Williams, a publishing director at Fourth Estate, she observes that celebrities aren't inspiring anymore, and people don't want to be them. Instead, she says, People desire to read about people who are normal and who they feel they can trust.
Authenticity.
Authenticity, yes.
Oh.
She even suggests this trend is a reaction to the shit show of a world we're living in right now, indicating a public appetite for stories about good people doing good things. And ironically, perhaps, the pervasive nature of social media, where celebrities constantly expose their lives, has also muted the need for A-lister memoirs. That immediate gratification of knowing what they wear or eat is now readily available online.
That's a great point. So it's a desire for grit and reality, a rejection of the curated perfect life.
Exactly. What readers are genuinely seeking now is the potent appeal of authenticity and these untold stories. Mark Burkowski, a celebrity commentator, highlights that people want sweat, tears, blood, and untold stories, actively rejecting narratives that portray a perfect life. These memoirs offer a raw, unvarnished honesty that allows readers to deeply identify with the experiences described. We have some brilliant examples. Christy Watson's The Language of Kindness, a nurse's heartfelt story, quickly achieved 100,000 paperback sales.
Wow.
Watson herself kept diaries, and her agent encouraged her to write narrative nonfiction, which she found flowed from the heart.
Oh.
Her vivid descriptions like witnessing a heart transplant and noting, "I've never seen anything as beautiful as Aaron's heart beating in front of my eyes," or describing the strange, sharp, biting metallic smell, which might be blood. They resonate profoundly.
You feel like you're there.
Absolutely. And Adam Kay's This Is Going to Hurt stands as another multi-award-winning bestseller by a doctor, demonstrating the wide appeal.
Yes. Huge.
Beyond the public appeal, these narratives serve a crucial humanizing effect for fellow clinicians. Take the example of former SBS sniper Ant Middleton's memoir, First Man In. It showed that military personnel are fathers, uncles, husbands, humans, not just fighting machines. This same principle applies forcefully to healthcare professionals, revealing our complexities beyond our clinical roles, our fears, triumphs, vulnerabilities, and simply our humanity.
Yeah, breaking down that barrier.
Precisely. Now, while there's an undeniable commercial drive from some agents and publishers seeking the next 5-minute wonder,
Yeah.
the underlying value remains. Christy Watson herself hopes that the inherent compassion and sense of community embedded in these new generation memoirs are not just a passing fad. She articulates it well. Nurses, teachers, police officers, firefighters, they might be ordinary people, but they're doing extraordinary jobs, and it's about connecting with people who've gone through something and come out the other side. This reflects a broader societal need for diverse, authentic voices. And within medical communities themselves, there's significant interest in these memoirs. Popular recommendations often include Oliver Sacks' The Man Who Mistook His Wife for a Hat, Atul Gawande's books, Paul Kalanithi's When Breath Becomes Air, Henry Marsh's Do No Harm, Jerome Groopman's How Doctors Think, and Richard Seltzer's Confessions of a Knife. He really merged art and science beautifully.
Some classics there.
Indeed. And this brings us to a crucial point about the wider system. If the public and fellow clinicians are so drawn to these deeply personal accounts, what does that tell us about the inherent, often untapped, value of narrative within everyday orthopedic clinical settings themselves? It suggests a fundamental human need for understanding and connection that goes beyond purely technical solutions.
That's a crucial insight, isn't it? It's clear there's an appetite for these stories, both from the public and within our own ranks. But let's move beyond the bestseller lists and cultural appeal. What's the actual therapeutic value of actively engaging with narrative, particularly through writing, for individuals navigating illness or, intense professional experiences like ours? How does it move beyond entertainment to become a tool for healing in a practical sense?
This is where it gets truly fascinating, I think. Writing, in this context, it's not merely a form of expression. It functions as a salve, acting as a kind of healing balm.
A salve, I like that.
And more profoundly, as the poet E.E. Cummings suggested, it's a tool that actively opens our minds and hearts to things that are deep inside us. Writing helps individuals to become acutely aware of and subsequently accept their personal battles or deeply held issues. And this awareness and acceptance are crucial first steps before they can effectively move forward to conquer these challenges.
Right, facing it first.
Exactly. And we have strong evidence for this. Decades of meticulously documented research by James Pennebaker, particularly in his book Opening Up, have scientifically proven that the act of creating a cohesive personal narrative and explicitly linking emotions with specific life events empowers individuals to take control over how those emotions and events impact their lives.
Okay, so there's real science behind it.
Absolutely. What's truly remarkable here, and a critical insight for us in orthopedics, is that this isn't just about feeling mentally better. We're talking about tangible physiological shifts that can reduce the very burden of physical disease. Pennebaker's groundbreaking research revealed that the sheer psychological effort of suppressing deep thoughts and feelings actually takes a measurable toll on the body.
How so?
Well, it impacts immune function, cardiovascular health, even our brain chemistry. Conversely, the act of articulating these experiences, of writing them down, can lead to remarkable physiological improvements, things like reduced blood pressure, lower heart rate, even enhanced immune response.
So this isn't just about emotional processing, but literally healing better on a physiological level. That's quite profound.
Exactly. For our orthopedic patients, this could mean potentially better healing, reduced pain perception, perhaps more resilient recovery from surgical trauma, or chronic conditions like persistent back pain or complex joint issues. It's a physiological tool, really, as
Hmm.
much as it is a psychological one.
Right.
For example, David Spiegel and Smith and colleagues back in 1999 documented that merely writing about past stressful life experiences resulted in a significant reduction of symptoms among patients diagnosed with chronic conditions like asthma or rheumatoid arthritis. Now imagine how this could directly impact an orthopedic patient managing debilitating chronic pain, or the long, arduous journey of recovering from a complex trauma like a major limb reconstruction.
Yeah, the potential is huge.
Mara Bobson further noted that this simple act of writing about bad times can be a potent and low-cost method of relieving pain and symptoms of chronic illnesses.
Low cost is key, too.
Absolutely. Mesardin eloquently stated that the only way through pain is to go through it, to absorb, probe, understand exactly what it is or what it means. Sarton believed that nothing that happens to us, even the most terrible shock, is unusable, and everything has somehow to be built into the fabric of the personality. Writing provides the means to achieve this integration.
Building it into the fabric.
Yes. Through writing, individuals can find order in chaotic experiences, engage in a form of profound self-analysis, and give form and sense to what has previously felt overwhelming or intangible. It helps to understand destructive attachment, for instance, in cases of addiction or chronic pain cycles, and allows individuals to consciously redirect their energy, providing a pathway to access truths often hidden from conscious awareness.
So how does someone actually do this? Is there a specific technique?
Well, for those considering therapeutic writing, the starting point is wonderfully simple. Individuals can begin by writing about any specific event, situation, or relationship that has profoundly affected them. For example, an orthopedic patient might write an unsent letter to the limb they've lost, or perhaps to the pain that dominates their life, detailing its impact.
Yeah.
Or a clinician, like one of us, might write about where they physically feel the emotion of bitterness or anger after a particularly difficult shift in the operating theater, or a complex patient outcome.
Right, connecting emotion and body.
Exactly. The key instructions are to write freely, ideally for at least 20 minutes without stopping. The focus should be on raw expression, not editing, grammar, or punctuation. And critically, it must encompass both the event and the emotions surrounding that event.
20 minutes, no stopping. Got it.
While individual writing is powerful, reading the work aloud and processing it with others in a supportive group environment, like Kaiser Permanente's Healing Through the Written Word group, can further enhance healing. This fosters honesty, objectivity, and self-confidence, allowing individuals to shift the power of the event from the event or experience itself into their own hands. They learn to understand their own story, sometimes discovering feelings they didn't even know were there, and begin to work through them with the support of others.
That group element sounds powerful, too.
It can be. And this brings us to a crucial point. If writing can be so transformative for individual patients and for us as practitioners, how might it then systematically enhance the broader fabric of clinical care and fundamentally improve patient safety within our orthopedic practices?
That's a profound shift of perspective, isn't it? Moving from being a passive recipient of care to an active co-author of one's healing journey. Professor, how does this deliberate focus on narrative fundamentally change the dynamic between an orthopedic clinician and their patient? And what are the tangible benefits we can expect for patient outcomes, and even in, well, challenging situations like adverse events?
Let's consider the practical application in orthopedics again. Narrative-based medicine, remember, is explicitly designed as a bridge between doctor and patient, facilitating a continuous empathetic exchange.
That bridge analogy again.
Yes, it's not about merely taking a history, as we've traditionally understood it, ticking boxes on a form. It's about actively building a history together, ensuring the patient's lived story remains central and alive throughout their care journey. This approach enables orthopedic clinicians to grasp not just the clinical details of an illness or injury, say the precise nature of a complex tibial fracture or the staging of osteoarthritis in a knee, but crucially, how illness affects the patient's life in its entirety.
Oh.
This includes their identity, their ability to participate in their family life, their relationships, and their aspirations, perhaps, to return to competitive sport or a demanding physical job.
The life contact.
Precisely. In managing chronic orthopedic conditions, which are so prevalent, there's often a significant tension between the voice of medicine, the objective, clinical facts, diagnoses, treatment plans we use, and the voice of life world, the patient's subjective, lived experience of their condition, encompassing their fears, daily struggles, personal values.
That disconnect, yeah, I see that often.
When patients are addressed predominantly or solely in the voice of medicine, studies show that patient satisfaction and, critically, treatment compliance often suffer significantly. Integrating narrative ensures both vital voices are heard, respected, and incorporated into care. This leads to a more holistic and effective approach to, for example, long-term rehabilitation after a major spinal surgery.
I can almost hear the collective sigh of orthopedic registrars thinking, another thing to add to the checklist. But seriously, Professor, how do we integrate these two voices without clinicians feeling completely overwhelmed or like they're just adding more tasks to an already packed day?
It's a fair point, but it's not really about adding more tasks. It's about shifting how we engage.
Mhm.
And the benefits are demonstrably profound in terms of health outcomes.
Okay.
Research indicates that an increased expression of patient narrative is directly linked to measurable physiological improvements. We mentioned things like decreases in blood pressure, reductions in blood sugar levels, alleviation of cancer pain, even improved lung function in asthma patients.
Mm.
Think of the implications for our orthopedic patients managing chronic pain, or those undergoing demanding post-operative recovery where stress can really impede healing. Beyond these physiological markers, patients consistently report greater trust and satisfaction with doctors who actively encourage and engage with their narratives. And this enhanced trust directly translates into better adherence to prescribed treatment regimens, physical therapy, medication, lifestyle changes, which, as you know, is absolutely crucial for successful orthopedic rehabilitation and long-term recovery following surgery or injury.
Compliance is key in orthopedics.
Absolutely. So, to achieve this, we need to cultivate essential narrative skills. These involve actively recognizing, absorbing, interpreting, and being moved by the stories of illness. This moves beyond passive listening to really active engagement.
Be moved by.
Yes. Narrative awareness and competence are direct feeders for the development of empathy. Empathy is cultivated through active listening and the practice of reflective summarizing, where the clinician accurately restates both the factual content and the underlying emotions expressed in a patient's story.
Reflective summarizing. Okay.
And it's vital to resist the pervasive clinical habit of interrupting patients. Studies have alarmingly shown that doctors frequently interrupt patients within a mere 18-21 seconds of them beginning to speak.
It's that quick. Wow.
Shockingly quick. Allowing patients the space of 60-90 seconds to fully tell their often rehearsed story can yield profoundly important diagnostic and relational information, significantly building rapport and trust information that might be vital for understanding a patient's hesitation to undergo, say, a knee replacement they clinically need.
Just giving them that minute or so.
Exactly. Crucially, narrative also plays a significant role in reducing adverse outcomes and medico-legal risk. It's a common misconception that most patient lawsuits primarily stem from clinical error.
Oh, really?
Yes. In fact, they often arise from breakdowns in communication and human connection. Key factors driving litigation include patients not feeling listened to, poor communication, a perceived lack of empathy or information, feeling devalued or disempowered, experiencing a sense of desertion, feeling abandoned or the family being excluded, and perceiving staff arrogance.
Communication breakdowns, not just technical mistakes.
Precisely. So, in instances of adverse outcomes, say, an unexpected complication after a hip arthroplasty narrative, humility offers a powerful framework. By requesting the patient to fully relate their story, encompassing their understanding and perspective of the event, and critically, the emotions they have experienced, and then carefully summarizing it back, inviting correction, and only then seeking permission to provide further clinical information, the situation can be dramatically improved and trust can often be rebuilt.
It changes the dynamic completely.
It moves the interaction from a defensive stance to one of understanding and respect, which is paramount in these difficult conversations.
Are there practical tools for this? Quick things?
Yes, there are. One such is the 3-minute mental makeover, or 3MMM. This brief yet impactful narrative exercise involves both patient and practitioner simultaneously writing responses to simple prompts, like what they are grateful for, 3 wishes they have, and a 6-word story of their lives.
6 words. Interesting.
It is. And this exercise has been empirically shown to significantly increase patient comfort and connection with their doctors, while reducing stress levels for both parties. Practitioners also report improved communication. This simple intervention can foster long-term coping strategies for patients as they learn to use narrative reflection as a tool for their own well-being, helping them navigate the often protracted recovery of an orthopedic injury.
3 minutes, that sounds manageable.
It is. And what's truly fascinating here is how these narrative practices lead us towards a more patient-sensitive, genuinely inclusive form of care. It moves us beyond simply treating the physical ailment to truly addressing the whole person, their fears, their hopes, their unique journey through an orthopedic illness or injury. Ultimately, it elevates the standard of care we provide.
It's clear, Professor, that narrative profoundly benefits patients and can even mitigate significant risks. But let's turn the lens onto us, the clinicians. The medical profession, particularly post-pandemic, has seen unprecedented levels of burnout, secondary trauma, moral injury. It's tough out there.
It really is.
How can narrative medicine offer a crucial lifeline in supporting our well-being and strengthening our professional identity, especially in demanding surgical and clinical environments like orthopedics?
You've highlighted an absolutely critical issue. The COVID-19 pandemic severely exacerbated issues of secondary trauma and moral injury for healthcare workers, underscoring an urgent and critical need for effective mitigation strategies.
They're still feeling it.
Absolutely. Statistics are stark. National survey data revealed over 50% of pediatric residents experienced burnout symptoms, a statistic that tragically mirrors the high rates we see in demanding surgical specialties like ours.
Yeah.
In orthopedics, long hours, high-stakes decisions, managing complex trauma, emotionally taxing patient journeys, that's the norm. Narrative medicine stands out as an accessible, diversity-honoring, low-cost, underutilized pedagogical framework that offers potentially revolutionary benefits for clinician well-being.
Accessible, low cost. That's good to hear.
Yes. Direct participation in narrative medicine group sessions, where participants engage in reading and discussing a poem, perhaps, or a piece of prose or a visual image, followed by writing and sharing their reflections, has been empirically shown to significantly reduce both burnout and compassion fatigue.
So group work helps clinicians too.
Immensely. Narrative interventions are critical in preserving empathy, enhancing self-awareness and perspective-taking, increasing emotional regulation, facilitating the complex process of grief after a difficult case, supporting trauma-informed care, and actively encouraging teamwork.
All things we need.
All vital. These benefits are particularly crucial for building staff resilience in high-stress environments, such as busy orthopedic operating theaters, emergency departments seeing major trauma, or fast-paced outpatient clinics. Here, narrative connections forged one-on-one between staff members or through structured programs like Schwartz Center rounds are directly linked to improved resilience. These aren't abstract benefits. They translate into tangible support for those on the front lines.
Schwartz rounds, yes, I've heard good things.
They can be very powerful. Furthermore, narrative medicine plays a pivotal role in fostering a robust professional identity. Engaging in reflective writing is a powerful mechanism for developing self-awareness, both on a personal and professional level. It allows us to process our experiences, clarify our values, and understand our responses to the challenging situations we face daily, like delivering difficult news about prognosis after a severe orthopedic injury or managing complications.
Getting sense of it all.
Yes. The concept of empathic witnessing, articulated by Kleinman, involves simply being with a patient and profoundly acknowledging their experience. This practice, often cultivated through activities like medical students reading each other's illness narratives, develops empathy in deep and lasting ways. Now, initially, such sharing might feel uncomfortable due to the enculturation into medicine that often discourages vulnerability.
That stiff upper lip culture.
Exactly. But students and studies have consistently found it a rare and invaluable opportunity to share emotional and physical vulnerability, deepening their appreciation for other people's experiences and views. This is particularly relevant for orthopedic trainees who are often thrown into high-pressure scenarios. And for healthcare professionals who unfortunately also become patients themselves, say, experiencing their own complex fracture or degenerative condition requiring surgery. Narrative medicine provides a unique avenue to explore the disorienting shift in power dynamics and identity tensions that arise, moving from caregiver to reliant. It helps in integrating that experience into their professional self.
Seeing it from the other side.
Yes. Beyond specific interventions, narrative writing inherently enhances self-reflection, fosters empathy, and directly promotes practitioner well-being. Developing reflective narratives as a lifelong learning practice, whether undertaken personally in one's own time, about a particular patient or situation, or shared with trusted colleagues, is described as a habit well worth developing.
A lifelong habit.
Indeed, this practice serves to relieve pressure, promote job satisfaction, and cultivate more effective and meaningful relationships, not just with patients, but also with professional colleagues. And at an institutional level, one academic medical center's longitudinal initiative incorporating narrative medicine activities saw a measurable improvement. Participants' mean distress scores on the Mayo Clinic Well-Being Index notably fell from above to below the national average.
That's significant institutional proof.
It is. What's truly profound here is how these deeply personal insights and reflections, when intentionally cultivated and shared, transform into a more robust, empathetic, and ultimately a more sustainable and fulfilling professional self for us as orthopedic specialists. It's about nurturing the human behind the surgeon or the clinician, ensuring we can continue to provide high-quality, compassionate care without succumbing to the immense pressures of the profession.
With all these benefits for clinicians, it's clear this has major implications for how we train the next generation. Let's shift our focus now to medical education. Professor, how are these narrative approaches, combined with structured patient feedback, actually changing the way we train the next generation of orthopedic surgeons and healthcare professionals? What does a truly patient-centered curriculum look like in practice? And what are the broader implications for the quality and safety of care we provide?
This really marks a fundamental paradigm shift in medical education. Clinical education historically followed a very clinician-centric model, didn't it?
Absolutely.
Heavily emphasizing university-based didactic teaching of biomedical sciences, participation in research, and bedside teaching of technical skills by specialist physicians. The Flexner Report model.
Right.
Now, while this model was undeniably effective for developing technical competence, it often overlooked the patient's essential participation in the educational dialogue. And indeed, technical skills themselves can lose relevance as technology and healthcare landscapes evolve.
True. Things change fast.
They do. However, the last decade has witnessed a gargantuan cultural change, driven by a growing appreciation for the powerful depth of insights that patients bring to the healthcare experience. This shift actively integrates patient perspectives, moving towards developing empathetic, responsive, and patient-centered professionals.
Bringing the patient voice into training.
Exactly. Zooming out, what this really means for us is that this isn't just an optional adjunct to traditional training. It's becoming central to developing clinicians who are truly socially conscientious, particularly in a field like orthopedics, where outcomes often significantly impact a patient's functional independence and quality of life.
Socially conscientious. I like that.
Exposure to narrative medicine measurably enhances trainee knowledge, skills, and attitudes. It significantly bolsters empathic response, improves history-taking and communication skills, crucial for taking a thorough orthopedic history that includes functional limitations and patient goals and aids in the formation of professional identity.
Better doctors, basically.
In many ways, yes. Medical students engaged in narrative medicine have demonstrated higher objective structured clinical examination, OSCE scores, and an improved consideration of the standardized patient's options. Beyond clinical skills, training that incorporates visual arts, for example, has been shown to increase students' tolerance for ambiguity and their capacity for critical reflection, invaluable when facing complex diagnostic dilemmas in orthopedics.
Tolerance for ambiguity. Surgeons aren't always known for that.
Chuckles. Quite. And while some students might initially perceive narrative medicine electives as fluffy or touchy-feely, studies confirm their vital importance in developing core competencies in communication, collaboration, and professionalism, which are mandated by accreditation bodies.
It's not fluffy, it's core.
Precisely. Central to this transformation is the integration of patient feedback into teaching practices. Patient feedback, whether gathered through quantitative scoring or detailed qualitative accounts, offers invaluable direct insights into critical aspects like communication skills, demonstrated empathy, active listening, patient empowerment, respect for autonomy, and patient education.
Hearing directly from patients about trainee performance.
Yes. One innovative teaching method involves integrating real patient stories and direct feedback into case-based learning. This approach profoundly immerses students in patient experiences, fostering an intuitive comprehension of patient-centered care principles.
How does that work in practice?
Well, for orthopedic trainees, hearing a patient describe the daily struggle of living with chronic shoulder instability, perhaps, or the fear associated with a planned spinal fusion, inject a practical reality into their learning. It highlights the true complexity of patient interactions and the crucial importance of empathy, communication, and ethical practice beyond just the surgical technique.
Makes it real.
Utterly real. Another highly effective method involves simulated patient encounters, where trained actors, briefed on specific orthopedic scenarios, provide targeted, constructive feedback based on their experience as a patient.
Ah, the simulated patients.
Yes. This creates a safe learning environment for students to develop and practice both clinical and interpersonal skills, for instance, how to explain complex surgical risks or deliver news of a delayed recovery without causing distress to actual patients. And the post-simulation debriefing is absolutely critical here for reflective learning, offering immediate actionable feedback.
Safe space to practice difficult conversations.
Exactly. Crucially, the inclusion of patient representatives in educational review committees adds immense depth and pertinence to the process of curriculum design and academic assessments. This ensures that educational strategies are closely aligned with the actual needs and expectations of patients. Some innovative schools, like Northern Ontario and Canada, actively involve community members in admission interview panels and curriculum development, fostering truly socially conscientious practitioners right from the outset.
Patients on interview panels. That's fantastic.
It's a powerful statement. Leading institutions are already implementing this. While Cornell Medicine has successfully integrated narrative medicine into various programs, including Essential Principles Medicine and the AAP program, these use prompts like literary excerpts, art, documentaries to stimulate discussion on diverse topics like medication adherence, trauma-informed care, chronic illness, health literacy, all directly relevant to managing orthopedic patient populations.
Integrated right into the curriculum.
Yes. In graduate medical education, residency programs like those at Yale with its Writers' Workshop and Weill Cornell with dedicated narrative medicine series for pediatric residents and tracks for emergency medicine residents incorporate themes like chronic pain, substance use disorders, graphic medicine, chaos narratives, palliative care. All incredibly pertinent for orthopedic training, where chronic pain management and difficult end-of-life discussions are increasingly common.
Really tackling the tough stuff.
Absolutely. And for continuing medical education, numerous opportunities exist for lifelong learning. Master's degrees in narrative medicine from places like Columbia, shorter immersive workshops. Reflective writing by clinicians is increasingly published in prestigious journals like JAMA and the New England Journal of Medicine, which now feature reflective essays, poetry, even fiction, providing vital platforms for sharing experiences.
It's becoming more mainstream.
It is. Even courses like the Protected Airway course, PAIC, at Weill Cornell, include a storytelling station where participants share accounts of challenging intubations, normalizing the often hidden anxiety, self-doubt, and fear experienced by clinicians, a sentiment undoubtedly familiar to orthopedic surgeons navigating complex trauma cases.
Normalizing vulnerability again.
Precisely. Which brings us to an important question. Given these clear and compelling benefits across patient care, clinician well-being, and medical education, what are the main obstacles stopping this from being everywhere in orthopedics? And how can we proactively overcome them?
It certainly sounds like a profoundly beneficial approach, Professor. However, yes, any significant shift in medical practice and education will undoubtedly face hurdles. What, in your experience, are the main challenges to effectively integrating narrative medicine into our busy orthopedic, clinical, and educational landscapes? And maybe more importantly, how can we practically facilitate its widespread adoption, especially in such a specialized, often procedure-heavy field?
That's the crux of it, isn't it? Translating these powerful concepts into routine orthopedic practice definitely have its obstacles. Our primary hurdle lies in the ingrained culture of biomedical pedagogy, which typically treats uncertainty as a negative.
Right, we like clear answers.
We do. Orthopedic training, in particular, often instills a need for definitive answers and precise interventions. Narrative medicine, by its very nature, actively names and explores areas of uncertainty, finding richness and learning potential in curiosity and, well, apprehending the unknown. This fundamental clash can make reflective writing feel burdensome or stressful for some learners, leading to that perception of narrative-based activities as unnecessary or touchy-feely.
The fluffy label again.
Exactly. We're trained to have answers, and narrative encourages us to sit with questions, which can be unsettling for a surgeon. Another challenge is the potential impact of negative feedback on clinician confidence. while constructive criticism is an indispensable part of professional development.
We all need it.
The concern exists that repeated or intensely negative patient feedback, particularly in the early stages of orthopedic training, might adversely impact a young surgeon's confidence. It could potentially impair effective learning or even foster defensive behaviors. We need to manage this carefully to ensure it's a growth opportunity, not a source of demotivation.
Finding that balance.
Absolutely. Then there are the significant logistical hurdles. Implementing systematic patient feedback and narrative practices requires substantial planning, dedicated resources, and, critically, precious time in healthcare systems that are already often overburdened with clinical and educational activities.
Time is always the issue.
It is. For a busy orthopedic registrar juggling clinic lists, theater time, on-call duties, finding protected time for reflective narrative sessions can feel like an impossible ask. This can involve developing new administrative protocols, investing in tech solutions to streamline feedback processes, and securing protected time in an already stretched environment.
Needs system support.
Definitely. Finally, ensuring fairness and representativeness of feedback is paramount. It is essential that the patient feedback collected is fair, unbiased, and genuinely representative of the diverse patient population we serve. Without intentional recruitment of patients from a broad range of cultural, ethnic, and socioeconomic backgrounds, there's a risk of introducing bias that could distort educational content and inadvertently deepen existing health inequities.
Avoiding skewed perspective.
Crucial. However, we do have proactive strategies for facilitating adoption. First, cultivating a safe and non-judgmental environment for any narrative sessions is absolutely key.
Safety first.
This means establishing clear ground rules from the outset, creating a space where all viewpoints are honored, and where uncertainty and ambiguity are not only accepted, but explicitly embraced as vital conduits to learning more about our patients and ourselves. Educators must actively foster an encouraging environment that promotes deep reflection and growth without fear of retribution.
Okay.
Second, building strong institutional buy-in and support is foundational. Fostering positive, collaborative relationships with clerkship and residency directors within orthopedic departments helps to secure the necessary dedicated time, physical space, and institutional support required for these activities to thrive and become integrated into core curricula. It has to be seen as central, not peripheral, to what makes a good orthopedic surgeon.
Getting leadership on board.
Essential. Third, strategically identifying allies and creative partners can be a practical first step. Departments like the Office of Student Affairs can often identify faculty and students who already have an interest or background in the arts. Furthermore, local community resources, poetry readings, theater performances, museum visits can be readily integrated into narrative medicine programs, enriching the learning experience without solely relying on internal resources.
Looking outside the hospital walls, too.
Absolutely. Fourth, leveraging existing resources and networks is key. Utilize readily available platforms like the Health Humanities Syllabus Repository, which offers a wealth of ideas and curricular materials developed by others. Joining communities like QPS Talk Time can also provide access to shared learning and support, connecting practitioners with like-minded individuals.
Don't reinvent the wheel.
Precisely. And finally, intentional engagement for diversity and inclusion is critical. Actively and intentionally engage with a diverse patient population during feedback collection. This ensures that the educational practices developed not only enhance social conscientiousness and cultural competence among students, but critically also work to lessen health inequities rather than inadvertently perpetuate them.
Making sure everyone's voice is heard.
Exactly. Stepping back for a moment, overcoming these challenges requires a dynamic, thoughtful, and continuously adaptive approach. This includes ongoing evaluation and modification of strategies, all with the ultimate goal of ensuring that narrative medicine truly serves the evolving and complex needs of both our orthopedic patients and us, the dedicated practitioners. It's about building a medical culture where the power of story is truly understood and harnessed.
Prof. Imam, this has been an incredibly insightful deep dive into a topic that clearly holds immense value for the future of healthcare. It's really inspiring to consider how deeply ingrained storytelling is in our professional lives and how intentionally cultivating these narrative skills can profoundly enrich our orthopedic practice and, well, our personal well-being too. There's that anonymous saying often quoted, illness is what the patient has on their way to see the doctor, and disease is what they have on the way home. It strikes me that narrative medicine, at its core, is all about ensuring that the journey home isn't just about managing a disease, but about understanding and integrating an illness or injury into the very fabric of a person's life, ultimately transforming both the patient and the practitioner in that profound process.
Beautifully put.
If you found this discussion valuable today, please do consider rating and sharing this deep dive with your colleagues. Professor Moimam, thank you so much for joining us on the deep dive.
It's been an absolute pleasure, truly. And I would just add for all our orthopedic colleagues out there listening, remember that the impact of the stories you hear, and indeed the stories you allow yourselves to tell, can be just as powerful and transformative as any surgical intervention or clinical treatment. Keep listening, keep reflecting, and keep connecting.
Indeed. That's all for this deep dive. Join us next time on the deep dive for another exploration into the heart of modern medicine.